So I think believe now it's time for Q&A. I guess we have a couple of surveys, but I do want to kick things off with Dr. Sassoon. Really a great lecture, and had not realized, I knew about the controversy. I didn't realize that the data was pretty definitive from what you're describing. First, I guess there are two practical questions. First is how long would you recommend waiting to patients before they undergo a spinal fusion after their hip replacement? And the second is I noticed that a lot of your data was like based on surgeries done before 2012. I'm wondering if the anterior approach, which seems to be really emerging as kind of a preferred approach, whether you think that'll make a difference in this dislocation risk.
Sure. I think those are both really good questions. Ultimately, I think that to address your first question, I think if the patient's able to, waiting a year would be a good idea. I do a posterior approach, and I have patients on precautions for 3 months, but I think patients achieve their sort of maximal recovery at about a year from surgery in terms of their strength and their stamina. But it's not always the case that a patient can wait that long. If there's pressing matters, I would say a minimum 3 months, but certainly if they're symptomatic, somewhere between 3 months and a year. If they're having very minimal symptoms or could be managed conservatively for a year, I try and get them out a year from their hip replacement. With respect to the anterior versus posterior approach, I'm a little bit biased because I'm a posterior approach guy, and I find that the positioning of the implants is the most paramount thing. Because really, in the cases where patients are dislocating with spinal deformity, it's a matter of bony impingement. And it's a matter of component placement. It's a matter of being able to trial implants. And I think all of those things are sort of facilitated by a posterior approach. I think that the anterior approach avoids potential immediate hip precautions for the average patient, but there's been no data really in the hip arthroplasty realm that suggests that an anterior approach in and of itself in these patients is preventative of dislocation. I think component placement using potentially dual mobility implants is going to have a much greater impact on patient outcomes.
Great, thank you. Hopefully I have some more questions. I do have some specific questions for each of your talks, Tom, John, and Raymond, but I think it's a great transition because we are just talking about total hip arthroplasty, which is arguably probably the most cost-efficient and clinically efficacious interventions that we have in all of medicine, not just in orthopedics or in surgery. And then we're talking about deformity surgery, where we're talking about surgeries that are certainly evidence-based, but have immense costs on the system. And I know you're all at academic centers, which means that maybe you're insulated from these things, or maybe it's your job to take on these cases, but you're also thought leaders being there. Just wondering what your take is on that, because we're in a era of diminishing resources and where we have to make decisions on where we're going to allocate those resources. And when it comes to spine surgery, should we be devoting these resources to more MIST lifts or bigger deformity surgeries? Tom, do you want to take this on?
Sorry, I was unmuting there. No, I mean, James, I think that's a reasonable question, and I think in this era of where we're looking at things with perspective of finite resources, it's a valid thing to ask. But I think when you look, I can't remember the exact year, but Raj Ramprasad did a study looking at the what you gained in terms of quality of life outcome measures, and really a lot of the spine surgeries in the deformity patients were at levels pretty close to total hip and total knee replacements, which we sort of always think of as a gold standard. So there is really ability to I think provide a lot of value here in terms of a limited resource environment, and I think we're not necessarily at a stage where we have to sort of pick one or another, but I think maintaining the strong pressure to generally make sure it's something that you are going to see that quality of life improvement and sustainable over a period of years with sustainable results. That pressure is always going to be there, but it's a legitimate, valid question.
Yeah, James, I think that's a great point. I think specifically with like deformity, I think it's been shown that I think having an adverse event or a complication or failure and take back, it sort of takes away the long-term sort of cost benefit, at least to the system. I think the challenge is, at least I think in our system, the administrators and the health systems and whoever is looking at implant costs, they're looking at episodes of care, so they're looking at, oh, look what Chaw's doing today. He's putting in like $20,000 worth of metal, and they're going to give him a hard time, or we use BMP, but they're not really looking at like the entire scope of that patient's care, longitudinally. I think that's the challenge. And I think that's why, you're seeing a lot of companies now come with customized rods and this and that, and showing that, if you avoid rod fractures and all these other things that happen in deformity surgery, then that translates to savings to the system. I think I'll share one little thing that I think we looked at our place recently was they put a blinded graph up demonstrating all the spine surgeons across the system who did T-lifts, right? And they had it plotted out like A to Q or something like that, cost per case. And it was pretty shocking that it ranged from like $5,000 to like $35,000 per case. And I would argue, I can't even imagine putting $35,000 worth of implants for a single level T-lift, but that's the range. So even in the degen world, you can see that depending on the technology or what you're using, that's a huge variation, right? So when you're just looking at that, not looking at granular data, but looking at per surgeon, you could see why an administration or a hospital would say like, hey, why aren't you guys more like the $5,000 guy versus the 35,000 person, so.
Those are all great points. Thanks. So some specific questions that came up, I guess, John, while we're still with you, any tips for preventing distal junctional problems? The question was whether there are like cement augmentation or any type of implant related tips or tricks that you have for avoiding distal problems.
Yeah, I think that's really tough. And, in some cases, we'll augment the distal screws, but I think a lot of it is just making sure that I use a lot of in situ rod benders to make sure that the rod is contoured to the screw versus using reducers and trying to force the rod down. And I think trying to be mindful of where you are in the apex of the thoracic kyphosis is very important. I think it's hard. I mean, there are a lot of cases where we do degen cases like C2 to T2 or C3 to T1, and it's not a great angle. The screws are kind of pointing vertically down to the floor, but you can't really justify going so far down. So I think there are a lot of nuances, but I think that what I found is really making sure that there's not any stress on those bottom screws. So it's really trying to use the in situ benders to contour to the screw head and to rod, and try not to use so many of the reduction instruments that are there. And cement augmentation, I think if a patient, let's say I've treated a patient with Forteo for 6 months or a year, in those cases, I'll always use cement up or down. But for patients who otherwise have decent bone quality, I won't.
Thanks, John. So Raymond, you actually mentioned that a lot of the sagittal parameters that we use in the thoracolumbar spine are based on a younger patient population. I think the average age was 51 in that Schwab paper. So, but you didn't really go on to make recommendations on, what in your practice, when do you just ignore it? When do you not pay attention to the high pelvic tilt, which we know can, I think, come pretty close to 20 once you get into patients in the 70s or so, I believe. I'd have to look at, there's a subsequent paper published by the same group, to their credit, about normal parameters in the aging population.
Yeah, so if you do look at that paper, they substratified, I think, just by decade, and so they looked at kind of the normal parameters, by advancing age. I believe in my talk, let me see. I mentioned, the age-adjusted norms on one portion of my talk. That was for an average age of a 75-year-old. Was SVA of under 8 centimeters, pelvic tilt up to even 25 degrees, and a mismatch up to 15 degrees. So certainly what we consider to be in the deformity range, but that was for average age 75.
So going back to my question, how do you implement that in your practice? When do you look at someone who's 66 years old and say, that's a deformity or that's not a deformity?
Yeah, I think that's a difficult question. One, I do go to the degree of pelvic tilt versus their pelvic incidence. If you're really, in the 2/3 range of your pelvic incidence is made up by your pelvic tilt, you start worrying that over time, that patient, as they lose their compensatory ability and strength, that's going to be difficult. I like to see the pelvic tilt certainly at least about in like half range or a third range versus sacral slope. So I really care a lot about pelvic tilt. But you're right. I mean, I think it comes down back to my point to something maybe a little less scientific even. It's just the patient's primary complaint. Is this truly a claudication related issue? Or is this really a structural deformity issue? And I think that, as you examine and challenge those patients and, see them walking and test their endurance, that you can get a sense of that. There are some nice things that I've seen other surgeons do. They have a patient walk for a period of time, and then they get their long films just to see, after they have fatigued their trunk muscles and their extensors, to see if there's a major difference in the parameters. So I think if you're kind of on the borderline, that's something that can help. But absolutely, as a patient gets older, I'm more likely to tolerate a degree of mismatch and malalignment.
Thanks, Ray. And finally, Tom, just one technical question for you. You talked about the ACR or basically X-lift type approaches with ALL releases. Do you usually perform open acetectomies if you're going to try to do a real deformity correction, so a hybrid approach, or have you had success with really percutaneous instrumentation after that type of ALL release?
Yeah, I think you got to really consider percutaneous only. Instrumentation is essentially holding whatever you're achieving in that interbody or anterior reconstructive space to really maximize the correction segmentally. You likely need to perform at least facet osteotomy at the level. So I would call, if you're going for that significant amount of correction, generally it requires something done posteriorly in an open fashion, or a very short segment specifically if all the correction is occurring at that one level focally.